And sorry about the slight delay. The topic given to me is optimizing biometry. There might be a slight overlap with what Dr. Victoria had to say. I would like to give a slightly different perspective on this. These are financial disclosures, though it has no relevance to the subject matter of this particular talk. Biometry, the history is almost as long as that of intraocular lenses itself, though we do know about Harold Ridley as the first person to put in intraocular lens. The first two lenses that he put in had a refractive surprise of about plus 21 diopters. Obviously, that's something totally unacceptable to both the physician and the patient. So since then, the quest has been on to get the absolutely correct refractive outcome. I've always found that whenever you prescribe spectacles, whether it's for a 10-year-old or whether it's for a 42-year-old presbyope or whether it's a person who has undergone cataract surgery, there is a certain amount of unhappiness that associated with it. And it's not just a question of ethics. It's also been well documented that IOL power calculation represents the single largest malpractice risk to a practicing ophthalmologist. So it is not just the excellence of cataract surgery alone, but what goes in preoperatively to ensure that we get an optimal outcome is extremely important. And finally, if the patient is not aware of the type of intraocular lens that you're using, the microscope that you're using, or the kind of machines that you're using, but he or she just essentially the outcome of your surgery, the way they are able to see fully with an uncorrected visual acuity for distance near and intermediate, especially if you're using multifocal lenses. So what is reasonable and what is achievable today is that if because lenses come in powers of the variations of about 0.5 diopters, at least most of them, I think the quest is on to lower down this to about 0.25 diopters. But ideally, if it's a spherical correction, you would be at least in 80% of cases, you should be getting it within 0.5 diopters of the target. As far as cylinder is concerned, now that we have toric lenses, we have laser refractive corrective surgery, femtosecond laser keratotomies, it's obvious that there are tools available for us to limit the amount of cylinder, also by positioning the kind of incisions that we are making, the length of the incisions that we are making, so that it's ideal that you leave behind the patients with less than 1 diopter of astigmatism post-operatively. If you are able an uncorrected visual acuity is much faster and more. I do submit that even if you don't have access to a laser interference biometry, you almost completely shift over to immersion A scan. As far as laser interference biometry is concerned, it definitely offers a significant advantage. When you are talking about ultrasound biometry, it's a large wave of ultrasound which goes into the eye, gets reflected from the retinal from the internal limiting membrane, and because especially in cases where there could be a posterior cephaloma like in large myopic eyes, the fovea may not be at the well of the cephaloma, but it might be on one of the walls, and you might get a fairly erroneous reading because you are getting the reflection from the area of retina, not precisely from the fovea. On the other hand, with the laser interference biometry, because it's a precise laser beam of 780 nanometers, you get it reflected bouncing off the fovea, the estimation is far more accurate. There is a slight difference in where these waves are getting reflected from. As far as ultrasound is concerned, it's from the internal limiting membrane, while in the case of the laser interference biometry, it is from the retinal pigment epithelium. The instrument already factors in the thickness of the retina that's incorporated in the measurements of the axial length. We do have both the IOL master and the biograph, which essentially work on the laser interference biometry principles. Both of these have certain nuances of differences, but I am not going to go into those. Suffice it to say that these give fairly predictable, reliable results. Routinely, all our patients get their biometry done both with the laser interference biometry as well as with the imaging A scan. And we do find that most often the axial length as well as the intraocular lens powers calculated do match up, and if it doesn't, we do tend to go back and look more deeply into these patients. When I initially shifted into laser interference biometry, routinely I was finding that the readings that we are getting with this was about 0.5 diopters less than what we are getting with the immersion A scan. I was not willing to accept that because except for occasional surprises, we are quite comfortable with the immersion A scan. Later on we found, and I am sure most of you realize, that there is a difference between the A constant that we use. When you're using an ultrasound, it's basically an ultrasound A constant that you need to use, or while if it is a laser interference biometry, it's an optical A constant. More the IOL master as well as the biograph has the algorithms incorporated in them, and the common lenses that you use, if you fill in the data, both the pre-operative, the post-operative and the refractive outcome into them, it can exactly give you the kind of A constant that needs to be used with the type of lens that you are using. Needless to say, every time you change technique, change the intraocular lens, this kind of customization has to be repeated. But as a rule of thumb, I have found that the optical A constant is about 0.5 more than the acoustic A constant. Usually it gives about 0.5 diopters less, and that's the reason you need to pump it about 0.5. You can also refer to the ULIP site, the user group laser interference biometry, which gives you the optical A constant for most of the intraocular lenses that are currently being used. But there could be racial differences, and what's given for the Western population may not be always applicable to the Asian population. As far as the axial length is concerned, whenever we find certain extremes, we look at it more carefully. Unless there is a documented evidence of prior anisometropia, if there is a difference of more than 0.3 millimeters between the two eyes, we would look at this eye again. It's always whether the fellow eye is a phakic, pseudo-phakic, or has a cataract or no cataract. We always insist that the biometry is done in both eyes. And if the axial length is beyond less than 22 millimeters or beyond 25 millimeters, again we would be more suspicious and look at this more carefully. The refraction, most often nowadays we are operating on eyes with 6/9, 6/12, and a reliable refraction is possible. The axial measurement should correlate with the refractive error that the patient was having pre-operatively. Having good, well-positioned echoes which are raising up quite steeply is important, and needless to say, the patient's cooperation has to be factored in. As I did mention, keratometry evaluation is also extremely important. Usually it's in the range of about 43 to 45 diopters, the average. If it goes less than 40 diopters or beyond 48 diopters, unless there is evidence of, there is a history of refractive surgery, again this is something suspect. And if, because of the phenomenon of enantiomorphism, usually K readings in the two eyes are quite similar. And if there is a difference of more than 1.5 diopters, you are going to look at it more keenly. And if there is more than 4 diopters of astigmatism, again, see it carefully. Measurement inconsistency, any difficulty in obtaining measurements, previous history of laser vision correction, and if the keratometry readings are not matching with refraction, maybe because of lenticular astigmatism, which the incidence of is not too high. So if there is the refraction and the keratometry readings do not match up, again you need to be extremely careful about what you are getting. As far as the formula itself is concerned, basically the good news is that as the currently available formula with the normal axial length of about 22 to 24.5 millimeters, 95% of our patients seem to fall into this group. Most of the formulas seem to work quite well. It's only in the extremes of refractive error it seems to become more difficult. We routinely use a SRK-T and a Holiday Q, Holiday 1, and it's a Hoffer Q for the shorter eyes, and it's Haggis L for the post-refractive surgery eyes. Holiday, the more the number of variables that the formula takes into consideration, the more accurate is likely to be the intraocular lens power calculation. It is because of this reason that the Holiday 2, which incorporates almost 7 different variables, seems to offer among the best results in intraocular lens power calculation, but unfortunately it's not incorporated in most of the currently available biometers. Essentially, all these formulae work well and give the most accurate results because of that, because of the ability to give an effective lens, estimating the effective lens position accurately. If this is not estimated properly, then most often these formulae tend to fade, and that's the reason that the more the number of variables that you take into consideration, the better are the results. There was a brief discussion on the post-LVC scenario. We are more and more facing this kind of a situation, and because these patients have been used to complete correction and vision without glasses, their expectations are also high. It's basically the cataract surgery in these patients is not a challenge, but the challenge is to get the correct intraocular lens power. We have made it a routine to give all our patients undergoing a refractive surgery, the keratometry reading, the preoperative refractive error, etc. Because whenever they present for cataract surgery, this data might be extremely useful. We routinely use the clinical history, the IOL master, and the ASCRS online. Basically, we have started using the Pentacam holiday report, and we have to still gain sufficient experience with this, and this is essentially just a comparison of the results that we got in a dozen patients which has been published. Basically, what we found was the ASCRS calculator, which is a very user-friendly calculator, and for your information, the APO has also got its own calculator on its website. You could access that. It seems to be giving the most reliable results as far as the refractive outcomes are concerned. Next is the clinical history method, and the Hegel, which is incorporated in the IOL master, seems to come a close third. But essentially, you need to look at these patients very carefully. And if you're as far as myopic eyes are concerned, it's a hyperopic surprise you get. And if it's a hyperopia, what has been corrected with the laser vision correction, it's a myopic surprise that you get. So in myopic patients, you are going to pump up the power you are implanting, and in hyperopic eyes, is going to be vice versa. And in any case, we do program the patients to tell them that sometimes there might be situations where the refractive arm would be suboptimal. This is a keratoconus patient in which case where we had extreme difficulty in getting good keratometry readings, and we are getting very different values. And this situation, we essentially went ahead and just did a primary cataract surgery, waited for 3 weeks, and then subsequently, this is just during the second surgery, we did a aphakic refraction, and the age-old method of multiplying it, the aphakic refraction by 1.75 times and putting in the intraocular lens power seemed to work quite well, and the patient was left behind with just a residual refractive error of 0.75 diopter subsequently. If we had maybe stuck on to doing it in the primary procedure, because of the various values that we are getting, we would have ended up with a suboptimal result. I do believe that optimizing biometry is a critical component of the refractive cataract surgery of the third millennium, and it adds to the excellence of the intraocular lenses, the current day phaco machines, and the other technologies that are available to us today, making cataract surgery so much more satisfactory. Thank you so much for your kind attention.
Thank you.